Dr. Sudipto Mukherjee from Pediatric Neurosurgery Department of National Institute of Neurosciences. My topics is actually a poorly diagnosed or underdiagnosed issue, that is Syringomyelia. But it is not uncommon. Here we face this type of Syringomyelia patient in our OPD frequently actually. Syringomyelia, by definition, this is a cystic cavitation of a spinal cord caused by various congenital inflammatory traumatic problem of brain and spine, and treatment should ideally directed the etiology of cyst, not the real disease, not the syrinx. Syrinx is a term which is came from Greek mythology. In 1546, by Steiny, he published a paper in La Dissection de Corpus in Humane regarding the Syringomyelia. Syrinx, actually there is a myth. The Syrinx name of a nymph in Greek mythology, and he cursed his lover as his lover betray with syrinx, and he tell you will not producing any good song by your throat. Syrinx is a tubular structure. Pathogenesis of syrinx. There are so many controversy regarding pathogenesis. In 1970, Gardner and McCurry say that is the expansion of Syringomyelia due to water hammer theory. That is, the CSF pulsation work like a water hammer, and it produces syrinx. But when we get syrinx in case of trauma, so the water hammer theory lost. There are some another theory for post-inflammatory syrinx, post-traumatic syrinx. William modified it by pressure theory. There are this modification, he tells the venous hypertension or venous pressure differentiation is an important cause of syrinx. Etiological classification. Chiari malformation, especially Chiari 1, is the most important coexisting etiology in the syrinx. There are some congenital etiology, especially in pediatric age group, tethered cord due to any cause. Maybe neural tube defect, maybe lipomyelomeningocele, maybe terminal myelocystocele, or maybe actual primary tethered cord is the common cause, also one of the common cause of Syringomyelia. Another is tumor, trauma, vascular malformation, degenerative stenosis, arachnoiditis, and infection. In some literature, they tell where the infection is the predominant cause, like our situation, the post-infective arachnoiditis may be the one of the important cause of syrinx. Treatment, as there are many etiology, as there are many theories, so treatment is also have some controversy. So, if no etiology are recognized, can we treat syrinx? If there are some, there are many questions in front of us. So, there is a big diagram. I can take it from the our Albright textbook, that Syringomyelia and Chiari 1 malformation. See, if there is existing hydrocephalus, we know there is a good theory, that is top-down theory. When there is syrinx, hydrocephalus, and there are some tethered cord, we can approach from top. So, we can approach to hydrocephalus first, and then syrinx, Chiari, and tethered cord next. So, there is no controversy in case of top-down theory. But if there is no hydrocephalus, we look for anterior compression present or not. If there is no anterior compression or no anterior disease, we can go for posterior fossa decompression. That may be posterior fossa augmentation by different techniques. That is a different issue. If there is some anterior disease, but it not compresses, so anterior disease is not the problem. But in anterior disease causes compression, so we can focus on it. Like if there is some craniocervical problem like AAD or something else, we can focus on the on that etiology, not on the syrinx, not on the Chiari. So that is another theory also. There are some predictive signs. If syrinx is associated with significant muscle atrophy and coexistence of syrinx more than 24 months. It is associated with ataxia, nystagmus. So outcome is not good. In recurrent syrinx, it is another issue. Here I show you some cases, about 4 cases, and I think our audience, our teacher will discuss about the cases. So this is some cases of Syringomyelia. This is a case of 8-month-old boy present with head enlargement, fontanelle bulbs, OFC in more than 98 percentile with lumbosacral myelomeningocele. See, this patient has big chiari and syrinx, septated hydrocephalus. So what we can do for these cases? We can follow top-down theory, or we can release the neural tube defect first, and this syrinx and chiari, what we can do, which one we approach first, which one we approach second, and which one is not approachable or no need of approach. Any comment from audience, please? Here what we did from top down theory, we perform CSF diversion first, then neural tube defect we process for myelomeningocele, then we observe for chiari. If the chiari not elevate chiari or syrinx, but if after a long time follow up, around 1.5 years, we see there is a still now compression, so we approach for syrinx and chiari. This is another case. See, this is a neural tube defect. This is a lumbosacral mass, possibly a myelomeningocele presentation in the later part of the day, and it is associated with syrinx. Can we do anything for it, or only we release this part or operate on this part? Any comment from audience?
First, the lipomyelomeningocele.
Okay, thanks. That is the ideal way, and we did it. We did lipoma and wait for this one. The third one, that is a compression in the atlantoaxial region, and there is a big syrinx. What we can do? We fix the atlantoaxial compression, or we do something for syrinx. What we can
compression
do
first.
Pardon?
Atlantoaxial compression.
Okay,
first.
we did it. Thanks, Dr. Tarek. Dr. Tarek is our new co-fighter in pediatric field. The last case, here we see there is some cervical compression and hollow cord syrinx. What we can do for these cases?
First, cervical compression.
Thank you. So really syrinx primary, if syrinx has some etiology, we can focus on etiology, not on the syrinx. But what happened in our OPD, I tell you that regularly patient family come to us that what we can do, and some doctors say there is a lesion and we must do some operation. But this is I show you a chart from our textbook. If syrinx is associated with some known etiology like hydrocephalus, like chiari, like tethered cord, we focus on that. If there is primary syrinx, we can check it with the clinical status of patient. If it is not associated with some clinical status, if it is an incidental finding, we will not do anything. And in some cases there is some anterior compression, so we will focus on anterior compression, not the syrinx. This is the message from the speech, that not focus, syrinx is focuses on syrinx, not focuses on MRI, focuses on the main etiology, focuses on the clinical picture. Thank you for patience hearing.
Thank you, Dr. Sudipto, we learned a lot from the discussion of Dr. Tariq and Sudipto. They made a plan or it's set up, I don't know. Anyway, it was a good discussion. Does anyone want to say, add anything? There is one more person. Okay, go ahead.
Dr. Moshir.
Dr. Mike though.
Thank you, Tariq.
Thank you for your nice presentation. I want to discuss about the second case. That is lipomeningocele with syringe.
Syringe.
So it is not usual case where in a lipomeningocele we see frequently there is a syringomyelia. So there should be some sort of tethering, I think. Tether cord may be there. So what was your approach to this?
Tethering.
That is a good question. We know according to Pang classification there are 4 types of lipomeningocele. In all type, you know, the tethering is associated. Lipomeningocele is itself a anchor.
Yeah.
What about the type that is dorsal, transitional, chaotic or terminal? It is itself a anchor and it may be associated with another primary tethering. So we must focus on excision of lipoma, and if there is associated tethering, so we must release the tethering. So two things in a sitting and waiting for the resolution of syringe.
All this complication comes when there is the embryologically, if you think, the closure of the neural cord there, those caudal neuropore, when it closes, and if it is incomplete, then all these things happen. And due to tethering, all these congenital abnormalities starts.
Actually, I differ with sir. The embryology is different for neural tube defect, for lipomeningocele, and lipomeningocele different type has different embryology.
Yes.
Neural tube defect is a defect of caudal neuropore defect, but lipomeningocele actually dorsal lipomeningocele associated with primary neurulation defect and rest 3 related with secondary neurulation defect. So lipomeningocele is a different entity, different pathology. I think in the later part of the day, another doctor will discuss about lipomeningocele. That is an interesting topic.
Okay, thank you very much. Oh, there is another person, please. Anish.
Thank you, Dr. Sudipto, for your nice presentation. But in case of large syringe, particularly in adult, is there any option to communicate the syringe with the subarachnoid space? I have done 4 cases, and 3 cases I have done syringostomy, and in 1 case I have put a shunt to syringe with the subarachnoid space, and the patients are running well.
Sir, if we see the this picture, if syringe is not associated with any primary etiology, and if there is no anterior compression, so and syringe persists, then the treatment is syringe shunt. This is the last sort of treatment.
Right.
This is not the first sort. We go for the primary etiology, we search it, and syringe correlate the clinical presentation. If anything is nothing is there and it is a hollow cord syringe or multiseptate syringe, then we can go for syringe treatment.
Syringostomy.
Syringostomy or maybe
shunt.
syringosubarachnoid shunt. There is another chapter.
If there is say with Chiari 1 malformation and syringe, the syringe is large and wide.
So treatment of Chiari, not the syringe.